Okay. So good morning, good afternoon, good evening to all of you. I welcome you all to the eighth academic meeting of TUGS India. TUGS is a simple group which started in back in October 2020 on Twitter, which was a group of upper GI surgeons, and over time it has now spread into various verticals of general surgery. And we are the I welcome you all to the 18th session of the TUGS India chapter. Which is Dr. Vikas Jain is the chief coordinator of TUGS India. Till date, 17 sessions have been held with topics ranging from diaphragmatic hernia, CA gallbladder, pancreatic mass, GERD, esophageal disorders, and so on. But we thought of having a topic which was something that every surgeon needs to know and something which is basic yet which needs a lot of training, and that's trauma surgery. So let's start with the three topics for today. I would first like to introduce the panelists for today's session. Uh, I would like to invite Dr. Subodh Kumar. Sir is a professor at the Department of Surgical Disciplines at AIMS, Delhi. The second panelist for the day is Dr. Mabel Vasnayak. Ma'am is the head of the department and the consultant in emergency medicine at Manipal Hospitals, Bengaluru. And the third panelist for the day is Dr. Krishna Asuri. Sir is the additional professor of surgery at AIMS, New Delhi. And now I would like to invite the first speaker for today. Uh, the first speaker and the topic is Principles of Damage Control Resuscitation by Dr. Girish Bakshi. Sir is the professor and head of unit at the Department of Surgery, Grand Medical College and Sir JJ Hospital in Mumbai. Sir has more than 150 national and international publications and lots of awards to his merit. It is a great honor for me to invite my mentor in general surgery as a first speaker for today. So over to you, sir.
Uh, Good evening, good morning, and good afternoon. I think everyone across the world is seeing, so that's why. Thanks a lot for the nice introduction, Parth. And thanks to Tug's team for inviting me to give this talk. I hope I can share my screen. Uh, just 1 minute. I'm just trying to figure it out. Just 1 minute. I'm just trying to share the screen. Just 1 minute. I think it's not getting. Shared. Unfortunately, yeah. Just can you see
Yes,
my
sir.
screen now?
Yeah, yes, sir. Yes.
Okay. So uh, good evening to everyone. Subodh Kumar sir is here. So we have learned a lot of things in trauma from him. And I'm going to talk about damage control resuscitation. And when we talk about damage control resuscitation, it is not only a simple thing like when I define it, it requires a lot of things. And I'm going to talk about each one of them, just the principles, because to know the complete DCR is quite a big topic, not to be covered within 20 minutes, but I would like to give the principles and anything which in the end you can ask me questions. So I'm going to talk about definition, indications, what are the phases of damage control resuscitation, what are the operative techniques of damage control surgery, which is a part of DCR, modification summary. Now, the concept of damage control came from basically First World War when the naval ships used to get drowned by the enemy torpedoes. Now, here the basic principle was to keep the ship afloat, to stabilize the vessel, limit flooding and fires. And the same principle we adopt in trauma victims who are coming to us with multiple injuries to keep the patient alive at any cost. And that is the was the concept of damage control resuscitation. So the aim is to limit the blood loss and prevent coagulopathy by combining hypotensive resuscitation, early airway control, and early and balanced use of blood products and other hemostatic agents. When we talk about damage control resuscitation, it is not a single technique, but rather a group of strategies which come together to prevent the lethal triad of coagulopathy, acidosis, and hypothermia. So to keep the patient alive, treat what is killing him first and treat the physiology. All of us have seen this diagram off and on that the deadly triad of hypothermia, coagulopathy, and metabolic acidosis, which is seen in trauma. Especially, Karim Brohi gave an article where they describe about acute coagulopathy of trauma sets in as soon as the patient gets trauma. Coming back to DCR, initially it started as a DCS, that is damage control surgery, where Stone and colleagues described it as truncated laparotomy in 1983 for warfare wounds, where they said that just keep the patient alive, control hemorrhage and contamination. Rotondo was the first time he published a paper in 1993 where he described the three phases of damage control surgery. And Johnson was the person who added the pre-theater or the pre-hospital or the phase which can be done in the casualty or the ER before the patient is taken in the operation theater. Sorry, my slides are not moving. Yeah. So damage control surgery is a concept of abbreviated laparotomy designed to prioritize short-term physiological recovery over anatomical reconstruction. That means we want the physiology to be corrected rather than anatomical reconstruction in trauma victims. And that is the tool which we combine when we are talking about ABCD of trauma initially, and then carrying over, saving the patient, then carrying over for definitive treatment of these patients. So the three principal phases were, phase one is the control of hemorrhage and contamination, which was initially described. Now the phases have changed. Phase two was resuscitation and stabilization in ICU. And this is the most important phase when we talk about. And then came phase three, where we are talking about a definitive repair. However, as one more phase was added, we had an initial pre-hospital care, then resuscitation at trauma center, then coming damage control surgery, followed by ICU phase, definitive phase, and then the reconstructive phase. So what we call the phase zero, which is either the pre-hospital or in the emergency department, is initially stabilization following the principle of ATLS of ABCD, and then carrying out the patient to the operation theater, which is going to last for about 30 to 45 minutes or at the most not more than 60 minutes. And then where your basic aim is to limit the contamination, temporary closure, control hemorrhage, and then shifting the patient the next phase to ICU. This is the most important phase where the intensivists and the surgeons work together along with sometimes the interventional radiologists, depending upon the demand of the patient, correct the physiology of the patient, especially the hypothermia, the coagulopathy, the acidosis, so that after 36 to 48 hours, patient is ready to undergo a definitive second surgery. When we are talking about these things, definitive second surgery means creation of ostomies. So that means when we are talking about average surgery, it is not ostomies. It is something else which I'm going to talk about, that is damage control surgery. And once the patient has gone through the damage control phase three, then he comes for reconstructive procedures, which may be over a period of maybe after 6 weeks or depending upon the stability of the patient. So what were the indications for DCR which were given? This was a good paper in 2012, which they said that if the patient presents to you with hypothermia, hemodynamic instability, coagulation, coagulopathy, severe metabolic acidosis, and requirement of MTP protocol, that means more than 10 units of packed cells, that is the time when you will be thinking that this patient is an ideal candidate for damage control resuscitation. To objectify it, in 2016, Harwood gave three parameters. He said anatomical parameters, physiological parameters, and laboratory parameters. Depending upon what is available at that time, you can take a call, and you can think about anatomic parameters when the injury severity score is more than 36. If the patient has penetrating abdominal or chest injury with hemodynamic instability, he is having a long bone fracture or a long bone amputation. Physiological parameters which you can assess immediately is when the core temperature is less than 35 degrees centigrade, systolic blood pressure less than 100, there is tachycardia, and when you talk about the PaO2 FiO2 ratio, it is less than 250, urine output less than 50 ml per hour. And if you have time, the lab parameters came later, because remember in trauma, by the time lab parameters come, you have already taken a call depending on the anatomic and physiological parameters, and these are just to confirm that your decision to do damage control resuscitation in these patients is justified. So when you talk about damage control surgery, you see it is only seen in unstable patient where fast is positive, and you take up the patient for immediate laparotomy, and this is the place where damage control resuscitation surgery comes into the. So what is phase one? It's a ground zero or built on the principles of ATLS, ABCDEU follow. You evaluate the patient rapidly, start the resuscitation. At the same time, you can do focus assessment sonography of trauma, ICD insertion for chest trauma. You can do a chest X-ray and a pelvic X-ray, and then move the patient immediately to the next phase, This phase, the initial phase, what you are doing at ground zero should not last for more than 20 to 30 minutes. And when you are doing this, another team is obviously telling the trauma team in the operation theater that please be ready. You will be requiring blood. So inform the blood bank. The patient may be in hypothermia, so stop air conditioning, start warmers. All this preparation has to be done by another team, which is in the OT, along with the sisters and the doctors. You will have to keep both a laparotomy set or a thoracotomy set, even a vascular set. At the same time, besides a general surgeon, you may require a vascular surgeon, an orthopedic surgeon, and a CVTS surgeon so that you, depending upon the injury, you can tackle it immediately at that time. Now, massive transfusion protocol, there has to be clear communication when you're going to activate it. Every institution has its own uh, principles of activating this MTPs, but the definition says that more than 10 units of PRBC within 24 hours means that the patient is having massive transfusion protocols. Obviously, in an institution, you may have the availability of thromboelastography or ROTEM or rotational thromboelastometry, which guides us in correcting the coagulopathy when the patient is shifted to ICU. So damage control resuscitation means permissive hypotension, a strategy for restricting crystalloids, at the same time accepting a limited period of suboptimal end organ perfusion. Here a word of caution that in cases of head injury, we want to maintain the cerebral perfusion pressure. So permissive hypotension may not be feasible in those patients who also have head injury. When we talk about hemostatic resuscitation, that means it has been clearly proved in various papers that when you are giving transfusion to the patient, these patients are already having coagulopathy. So always give them PRBCs, platelets, and FFP in the ratio of 1 is to 1 is to 1, which gives a better prognosis in the long term. This is the common picture which will be seen in so many PPTs that this is 1 is to 1 is to 1 ratio, which has been proved to be useful. When you talk about damage control surgery, as I was telling you, that when you're preparing the team, it is not only laparotomy, it may be thoracotomy, it may be vascular control, it may be orthopedic surgery. So that is why you will require a whole team of surgeons to deal with this patient to have an optimum outcome. The principles are simple. You control the hemorrhage if it's with whatsoever the vessel is bleeding, you can control it by ligating it. Prevent the contamination. If the bowel is already perforated, don't try to suture it. Just staple it, or if you don't have stapler, just on the two ends of the perforation, just take a simple roller bandage or something and tie it, and avoid further injury. You're not going to do definitive repairs or a section anastomosis thinking that, okay, you may be very fast surgeon in doing this, but at that point, the thing is that you go in fast and come out fast. So when you're doing all these things, you have at the head the anesthetist, who is a very important person because he's going to take care of the parameters intraoperatively. And there is a good coordination between surgeons and anesthetists regarding the availability of blood and blood products. At the same time, your staff nurse who is going to assist, you have to talk to her and take her in confidence regarding the requirement of the instruments, vascular instruments. Auto transfusion set may be required if the patient is having a thoracic injury where there is a thoracic hemorrhage, then the same blood can be used because thoracic cavity is not contaminated unless and until it's a penetrating injury or it has come to you quite late. And obviously, you have to have good assistance with you, besides giving antibiotic prophylaxis and tranexamic acid. So always a general anesthesia, burp maneuver with cricoid pressure. There is no contraindication to this. It's a life-saving procedure, so GA is always given. Now, this is the ideal position of the patient who has got a trauma and abdominal trauma. And you start from midlines, running from the xiphoid to pubic bone. And there are three passes: skin, subcutaneous tissue, land on linea alba, divide the fascia, and enter the peritoneum. You have to enter the peritoneum as soon as possible and divide the falciform. As soon as you enter, the first thing is you do suction and put four quadrants mops or towels. We normally use green towels to pack it, and then gradually remove pack one by one in one of the quadrant, and then try to see or control the bleeding. In the meantime, the other three towels which you have kept will put the pressure and control the hemorrhage if all those four quadrants have, if the other three quadrants have some bleeds. We all know that perihepatic packing of the liver, don't try to do definitive surgery in these cases because they are bleeding and the patient is unstable. So just do a perihepatic, do a Pringle maneuver if you can see something. If you have a good angiography backup, you can do this later once the patient is listening. You can just put perihepatic packing and come out. Similarly, splenectomy has been advised, provided you can do it very fast or it is a shatter speed. And if you are not able to do, don't worry, just control the pedicle. Just take the pedicle tie, and that's more than enough because you can do it later. Majority of the pancreatic injuries are grade 1, 2, 3, so you're lucky, just good drainage. However, those injuries which are grade 4 and grade 5, where there is a pancreaduodenal complex injury, here, just initial debridement, control the bleeding, control the contamination, and come out. Good drainage is something which you normally do for these patients. It has been advised that abdomen vasculature, you can tie almost majority of the vessels right from internal iliac axis, as well as in the carotids in the neck. When you're tying these vessels, there have been incidents, obviously you're thinking about gut necrosis. So it is better if you can take care of the vessels rather than the branches rather than the main pedicle. However, in a life-saving procedure, you may require an intervention radiology to help you later, initially by putting just pressure. A vascular surgeon is of help in these conditions because he can guide you in venous. Almost everything can be taken care, and literature has defined.
One moment.
Hello. Okay.
Still on it.
There is something which is going on. I don't know.
I'm having a problem with the connection.
I'll
Let's try again in a while.
Hear me because I am getting this.
yes,
Hello.
sir. I could hear
Oh,
that.
oh,
I'll mute
what is
whoever
this?
is it.
Yeah, I don't know. That's right. Okay, so now if you are thinking that there is an IVC bleeding or a tributary of the IVC which is bleeding, you can do extended coccus where you take the duodenum and the infra and the extending coccus means you take the duodenum as well as the colon on one side as well as the cecum, do a cattle brush maneuver, and then you can have an excess directly in the retroperitoneum. Now remember this thing, this is just to put the pressure and come out so that you can just or ligate it with the vessel. Similarly, you can do a medial visceral rotation depending upon if there is a major arterial ooze coming off the aorta which is uncontrollable. Simple thing is if you can pack or you can just ligate the vessel and come out. Pelvic binder is essential in the beginning, and when you are opening these patients, you can also do a pre-peritoneal packing. However, this is only done in patients where you cannot have other stabilizing procedures. However, if there is an external fixator or an orthopedic at hand, he'll be helpful in controlling this. Majority of these bleeds will require intervention radiology friend later on. Right now, the basic purpose is just to control the hemorrhage by pre-peritoneal packing. Surgery is rarely required. However, if you have opened it for some abdominal trauma and you happen to see this, yes, then you can do all these maneuvers. The renal pedicle injury, if there's a shattered kidney, you can just ligate it and come out. Don't try to remove kidneys. If you don't try to do nephrectomies, obviously here it is written that always palpate the contralateral kidney. If there's an isolated injury and you have controlled it, you can do a nephrectomy. But the basic purpose of DCS is that see how much time is going on, save, and time is the essence because you have to shift this patient back to ICU after this. So staplers, bowel clamps, even umbilical tapes can be used to control the leakage. You are not going to do any definitive repair. You can quickly suture, but what I will prefer is it. Karim Brohi said that you can suture, but we prefer that we just tie umbilical tape and come out because that's the time. Yes, time you have to take. In GIT, as I have told you that the non-viable bowel, you can have a relook procedure, just control the contamination coming out from the perforations so that you can isolate that loop on both the sides by tying umbilical tape or stapling it by the linear stapler. Obviously, as you are planning to explore these patients after 48 to 72 hours, depending upon the physiological correction of the physiological parameters. These patients will require temporary abdominal closure. You can use a Bogota bag. A simple thing what we do is we take a Eurosac bag in our setting and then we suture it. Some people have used meshes. Some people have used temporary vac. Some people have, as you can see, just the towel clips. However, majority of the times it is very easy to use a Bogota bag, which is just nothing. What we do is we take a Eurosac bag and open it and then suture it to the edges of the wound. Now, damage control thoracotomy also is a part of that, and pulmonary tractotomy or stapling of the cardiac wounds is a part, or simple lobectomy or pneumonectomy you can do. That's why you should have a vascular thoracic surgeon. And if you're not a trauma surgeon who is used to doing anterolateral thoracotomy, then obviously you will have to resort to calling these people. Vascular injuries, limb viable, damage control, shunt is not possible in trauma. You can just ligate the vessel and see it later. Now, whenever you have contemplate a vascular injury which has occurred, and if there is some repair which has not been done, then there is going to be congestion. So you do a fasciotomy, you do temporary intravascular shunts, stabilize the fracture externally so that you have an external, you have got an orthopedic colleague to do it. And this is the most important phase when we talk about damage control resuscitation, because this is the ICU where you are going to optimize this patient, correct the physiological abnormality which is caused by hypothermia, coagulopathy, and acidosis. And you have got next 36 to 48 hours. A multidisciplinary team effort is required where you will require surgeons, intensivists, anesthesiologists, intervention radiologists to take care of all these things. The basic aim is to correct the physiology and biochemical parameters which have been deranged by all these the lethal triad, so that you can take up this patient after 48 to 72 hours as early as possible, ideally, for definitive repair. Now, timing is critical. Once you have done your resuscitation, which includes correction of coagulopathy, correction of hypothermia, and obviously you have corrected the acidosis, then you can take up these patients for definitive surgery. And there you can obviously do a tension-free abdominal closure, because now the patient is hemodynamically stable, physiologically corrected, and you have survived that initial phase of 48 to 72 hours. Now, this is the phase when you're talking about posterior portion of the transverse mesocolon, some missed injuries which may occur in these patients, especially the posterior retroperitoneal surface of the colon. And then you should ideally see that if you're contemplating injuries, depending upon the mechanism of injury. Obviously, there are certain complications associated with this. Damage control surgery is abdominal compartment syndrome. There could be enterocutaneous fistulas which can occur. Sepsis is another part, because though you have tried to control the contamination, but yes, it can be there. Pancreatic injury can be recognized by the presence of tensely distended abdomen with elevated peak airway pressures. And obviously, the mechanism of injury guides you which organ is injured. Compartment syndrome in the abdomen will also result in hypoxia, oliguria, and that's why you may resort to doing a temporary closure even after some definitive repair in such patients where the bowel edema is going to be progressively increased. So you have to know something about abdominal compartment syndrome when you're going to deal with these patients, because whenever the pressure goes above 30 centimeters of water, you are thinking that this patient will develop abdominal compartment syndrome, which will be manifested clinically by oliguria, anuria. You get a lot of resistant in ventilation, elevated peak airway pressures. So in short, if you sum up damage control resuscitation, it involves rapid anatomic control, permissive hypotension, sparing head injuries, early transfer strategies. You have to limit crystalloids, rapid diagnosis and decision, and obviously antifibrinogen and other things to correct the coagulopathy. DCR is a vital part of the management of multiple injured patients, should be performed before he gets metabolically exhausted. Delay in the decision to perform damage control resuscitation contributes to higher morbidity and mortality. You always require a multidisciplinary approach in trauma and coordination among various teams. It's very important that by the time you're planning the patient to shift to surgery, the surgical teams are aware that what they are dealing with. So there is a communication. One of the team members from casualty or the emergency ward communicates with them. And this will only give the best results. Preparedness for disaster is the key to successful managing it. So that's why you should have some mock drills or something where you have these things, that how the preparedness and how the coordination among various teams is going to be. Thank you. I bring my greetings from Grand Government Medical College and Sir J.J. Group of Hospitals. This was a big topic. I tried to summarize it by just giving the principles. I hope I'll be happy to take any questions if there's.
Thank you, sir. You have given a great overview of the trauma management, with starting from damage control resuscitation. As of now, I cannot see any questions in the chat box. We will take all of them together with the panelists, sir. And we can now proceed with the second talk. The I would now like to invite Dr. Soumya Ghoshal to give our second talk, which is on evidence-based management recommendations for liver and splenic injuries. Sir is an assistant professor in the Department of Surgery at AIIMS Nagpur, and he has done his MCH in trauma surgery and critical care from AIIMS New Delhi. So over to you, Dr. Soumya Ghoshal.
Am I audible, Dr. Parth?
Yes, sir. Yes, sir.
Thank you. Let me share my screen first. Is my screen visible?
Yeah.
Okay. So, good evening, everyone, and welcome to my presentation. Again, am I audible, Dr. Parth? Hello?
Yes, sir. Audible, sir. My
Okay.
screen is also
Okay.
visible, sir. Please, sir.
Okay. Thank you. So, it's my great honor to speak in on this platform, especially in front of Dr. Subodh Kumar, sir. He is my mentor, my guru, my guide, and this talk would not have been possible without his constant motivation and guidance. And it is true in the context of the topic today, because he was one of the cornerstone for development of a very beautiful clinical practice guideline for management of blunt solid organ injury in Indian scenario. And this guideline was meant for those who are taking care of trauma patient in a resource constrained setup. So the first objective of my talk is to take you through the development of the first Indian clinical practice guideline applicable in the resource restraint setting for management of blunt solid organ injury. And the next objective is to make you understand about the specific therapeutic strategies for non-operative management and operative management through the available evidence as we go through the guideline. So let me first take you to a case scenario. A 16-year-old boy, bicycle rider, hit by a bullock cart. He was presented in the emergency department after 12 hours of injury. His primary survey was normal. He has patent airway, breathing is fine. He is hemodynamically stable. Focused assessment with sonography in trauma fast was positive for fluid inside the abdomen. And a secondary survey revealed mild tenderness in the epigastric region. So what will be your next line of management? A CCT torso, isn't it? And CCT torso revealed a great force splenic laceration with moderate amount of hemoperitoneum. So what will be the next step? Do you go for non-operative management in this patient, or you will go for a splenectomy or prophylactic angiomodulation for splenic vessel? Patient is hemodynamically stable, and this is important because the initial management, as aptly said by Dr. Girish Bakshi sir, is dependent upon the hemodynamic status of the patient. The initial management starts with A, B, C, D, E. And this is what we call the bread and butter algorithm for all trauma surgery. Patient will be either hemodynamically unstable or he will be hemodynamically stable. If he is hemodynamically unstable and does not respond to the initial fluid challenge, then he is termed as non-responder. Any non-responder and transient responder will go straight forward to the operating room for damage control surgery and damage control resuscitation. And this part has been covered by Dr. Girish Bakshi sir wonderfully. So I will not go into that. My focus will be on non-operative management of the solid organ injury in hemodynamically stable patient or a responder. Non-operative management is not merely an observation. We call it a masterly inactivity, which is a very much an active process. Let me elaborate further. To have non-operative management performed, we need to have large amount of resources. We need to have 24/7 availability of trauma surgeon, surgical intensive care unit backup, blood bank facility, operating rooms, and importantly, advanced imaging technique with IR facility, that is intervention radiology facility. And to perform non-operative management, we need to have a team effort, a robust trauma system in place. The components of non-operative management are very clear. Patient has to undergo serial clinical examination. They should be monitored with lab values. Imaging and adjuncts of non-operative management like intervention radiology with angioembolization has to be done when required, and patient has to be monitored till the normalcy is reached. But the questions are how frequent that serial clinical examination should be done, which lab parameters should be monitored, which imaging technique and adjuncts of non-operative management has to be applied and when, and what do you mean by normalcy? What is the definition of normalcy? For how long patient has to be monitored in the hospital setup? Suppose our patient lands up in a facility where resources are limited, so then what will we do? So the trauma care system in India is heterogeneous in nature. So Indian Society for Trauma and Acute Care, ISTAC, proposed an idea to formulate a clinical practice guideline for management of blunt solid organ injury to provide an evidence-based operational framework for the healthcare professionals and institutions in a general body meeting. Three trauma experts, including Subodh sir, suggested the topics. A guideline development group was formed for comprehensive and systematic digital literature search. And the group assessed the available evidence regarding each and every research questions in view of with the review process. And those review was deliberated in another meeting where the trauma expert guided the discussion into a consensus. And then the guidelines were edited by respective authors and it was compiled through an extensive internal and external review system. Guidelines are evidence-based. Summarized evidence were categorized on the basis of susceptibility to the bias. The evidence was then translated into the clinical practice guideline, a set of recommendations based on the nature of the evidence, the applicability of the evidence to the population of interest, the cost involved, the knowledge of the healthcare system, and beliefs and values of the panel. And the end result is this: management of blunt solid organ injury, an ISTAC consensus guideline. Several topics were covered, and I will focus on three topics: non-operative management, non-operative management of blunt liver and spleen injury, role of interventional radiology, and operative management. Most evidence available are derived from the retrospective studies and few prospective studies, and very few Indian data exist. And all of them shows high success rate with non-operative management, provided the patient is admitted in a facility equipped with adequate resources. Evidence also suggests that high-grade injury is a risk factor for developing complications. And most common complication is failure of non-operative management. Most of the failure of non-operative management occurs within 48 to 72 hours of injury. So it is important to have intense monitoring of the vitals and serial clinical examination. Initial hematocrit is important, and fall of hematocrit suggests ongoing blood loss. Regarding the hospital stay, a randomized control study evaluating early discharge of blunt liver and spleen injury shows no difference between day 3 and day 5 discharge in terms of unplanned follow-up, admission, or complication. So based on these evidences, ISTAC recommended 4-hourly monitoring of 4-hourly serial clinical examination for patients for first 48 to 72 hours, measurement of complete blood count and ABG every 6 to 12 hours for the first 48 to 72 hours. Baseline coagulation profile has to be performed and should be repeated as per requirement. They also recommend ultrasonographic examination at 48 to 72 hours because of chances of complications are high at this time period. CT scan need not to be repeated unless there are clinical or laboratory signs of complication, and at least 3 days of hospital stay for any grade of injuries is recommended. Now, turning our attention to the intervention radiology part, it is an important adjunct of non-operative management in blunt liver and spleen injury. It is indicated if a patient is hemodynamically stable and there is evidence of vascular injury like pseudoaneurysm formation, arteriovenous fistula, or any contrast blush in primary or follow-up imaging, or patient is having any evidence of ongoing blood loss. But what about our patient, that 16-year-old boy with grade 4 spleen laceration? Does high-grade liver and spleen injury needs prophylactic angioembolization? So the evidence says that the need for splenic artery angioembolization and pseudoaneurysm formation on day 5 follow-up is significantly more if high-grade splenic injury is not treated with prophylactic angioembolization. So ISTAC recommended prophylactic angioembolization in grade 4 and grade 5 splenic injury, but in as the incidence of angioembolization related complication rate is higher than the benefit of doing hepatic artery angioembolization in this scenario. But what if angioembolization facility is not there? For example, our case, if he lands up in a resource restricted hospital, then what? Failure rate of non-operative management is higher in high-grade splenic injuries in absence of facility of splenic artery embolization. So the best option will be to transfer this patient to a trauma center, isn't it? But that may be sometimes risky or not possible. Thus, ISTAC came up with a best practice statement that operative intervention should be performed in all cases of splenic vascular trauma if an intervention radiology facility is not available. And that is the beauty of this clinical practice guideline, which is applicable to the trauma population in India. Now, let us move on to the operative management. As I mentioned earlier, operative management is indicated in all hemodynamically unstable patients of blunt liver and spleen injury, regardless of its grade. Many operations are available, but believe me, the first three options, compression and packing, topical hemostatic agents, and topical energy instruments are the most important tools for hemostasis. These are effective in 99.99% of cases. Rest of the procedures like suture, tracheotomy, segmental resection, total vascular exclusion, atriocaval shunts, these are more mentioned in literature than any patient survive. So, ISTAC recommended that damage control approach is the approach of choice in hemodynamically unstable patient, and major bleeding can be controlled with perihepatic packing alone or with some combination with the adjuncts, and nothing short of splenectomy. For hemodynamically unstable splenic injury patient, especially in adults. I will conclude my talk by saying that more and more evidence is coming, so we need to be updated as we progress. Our ISTAC guidelines will also need to be updated as new pieces of evidence come, especially in Indian scenario.
Thank you, sir, for a wonderful
Uh,
presentation.
so, hello.
Yes,
Actually,
sir,
my
go on.
screen suddenly stops sharing. So I just wanted to say that we have to update our own guideline and we have to generate our own data in Indian scenario so that this guideline is more applicable in our own setup, considering the resources available. Now I will request Dr. Vivek Kumar to take you through the rest of the guidelines, and I will be happy to answer any question after the session is over. Thank you.
Thank you, sir, for an excellent presentation on the STAC guidelines. You have introduced us to the STAC guidelines, how the guidelines are formulated with so much of deliberations and discussions. And you have also told us about the liver and splenic injuries. Now, I would like to invite Dr. Vivek Kumar, sir, to discuss the second part of this lecture. Sir is also an assistant professor at the Department of Surgery at AIIMS Nagpur. Over to you, sir. Dr. Vivek, sir. Yes, sir. The screen is visible.
The screen is visible. Can you hear me?
Yes, sir. Yes, sir.
Yes, we can hear.
Okay. Is the screen full screen?
No, sir. You have to click on the full slideshow.
No.
Uh, yeah, this will do. Not exactly, but this is the presentation view, sir.
Is this a full screen or can you see two split screens?
Sorry, you have disabled the screen sharing. You will have to start again. Your screen is visible now.
Yeah, thanks. So thank you, Soumya, uh, for the backdrop of the topic, and very good evening to all the respected faculties and all the delegates. So I'll be continuing the topic furthermore. Soumya discussed about the non-operative management. What are the prerequisites? What are the patient selection, and what are the operative indications in case of failure of non-operative management of blunt trauma injuries. So I'll be talking about the special scenarios, the critical care issues, and what is the time which you want to admit the patient and discharge the patient. So talking about the critical care issues, first thing which comes to our mind is what are the ventilatory settings? So there is a level 2 evidence that hypoxemia should be avoided in all the patients, and a normal ventilation should be maintained. And there is a grade A evidence that a low tidal volume ventilation is very good for all the patients receiving mechanical ventilation following a solid organ injury. What should be the ideal hemoglobin level in a patient with liver injury or a splenic injury? So any dip in the hemoglobin is indicator of bleeding in a patient. So if a patient is having a hemoglobin of 10 on the first day and 9 on the second day and the 7 on the third day, that means the patient is actively bleeding and he should undergo either angioembolization, or he should undergo a operative intervention if the resources are constrained. So a target hemoglobin of 10 grams per deciliter in a high risk individual, and if the patient is very stable enough, having concomitant injuries and admitted for more than 5 days, 6 days, a 7 gram per deciliter is enough for the patient. The third thing is whether to measure serum lactate and base deficit regularly. Yes, it is recommended that routine measurement of serum lactate or base deficit is recommended because it is a very good denoter of the shock in a patient, and it is very early, means before you can diagnose a patient with shock by dip in hemoglobin or anything. You can diagnose a patient in shock with serum lactate and base deficit. So coagulation profile, yes, it should be monitored regularly. What is the target systolic BP and mean arterial pressure in a hemodynamically unstable patient with blunt trauma, solid organ injury? So basically, a mean arterial pressure of 50 to 60 is enough, and a systolic BP of 90 to 100 is enough for a patient with blunt liver injury or a solid organ injury. It is a grade B recommendation. That means the patient will not bleed much if you want to go to a higher level of systolic of 120 or 130, and there will be no cerebral hyperperfusion if you go below 90. So a BP of 90 to 100 is enough. A very important question which comes to mind always, that what should be the IV fluid which should be administered to the trauma patients. So it is a well-known fact that aggressive fluid management leads to increased complications in the trauma patients. Trali and pulmonary edema and cellular edema, everything. So the fluid should be restricted, and as soon as possible, we should always switch to the blood products. So there is a grade B recommendation that as soon as possible, we should switch to the blood products, and restricted volume of balanced crystalloid should be used in trauma patients. ATLS has now recommended that only 1 liter should be given, and by the third vac, the third bottle of 500 ml, you should be ready with the bloods. So that is good enough guidelines by ATLS also. And coming to the E, exposure, what should be the target temperature? So euthermia should be maintained always throughout the treatment phase, either from the pre-hospital care to post-hospital care. Euthermia should be maintained because it will land the patient into the triad of death that causes coagulopathy and acidosis. So, what is the ideal mode of like a patient comes to you and now he has been stable and you have put the patient into non-operative management and now you want to give the patient a thromboprophylaxis. So, what should be the modality? Because there is a chances of bleeding if you go for heparin, and if you don't go for heparin, there are chances of DVT and all that. So there is a grade B recommendation that mechanical thromboprophylaxis is initially very good for BLI, and after 3 days or 4 days, when the risk of bleeding is very low, then you can go for combined mechanical and pharmacological thromboprophylaxis. Like you can go for low molecular weight heparin and all that. And of course, low molecular weight heparin is preferred over fractionated heparin. That is also a grade B recommendation by STAC. Abdominal girth charting is very commonly used all over the world, but there has been no literature supporting the thing or recommending the thing. So there is a grade D recommendation by the persons who have presented the case scenarios and all that abdominal girth charting may be considered along with the vital parameters, because we go for heart rate, BP and everything, and we also go for abdominal girth charting, but girth charting as such is not mentioned in any of the literature present on the internet. So girth charting is a very good tool and it may be considered. That is a grade D recommendation by the ISTAC. So coming to the special scenarios, especially the pregnancy. So it is a level 2 statement recommended in the ATLS, recommended in the METOX, recommended everywhere, that the principles of trauma care management are the same in the pregnant females as well as the geriatric males or females and the pediatric population. And all the women of the reproductive age with trauma should be considered pregnant. Anywhere above 16 should be considered pregnant, and a UPT should be done before any imaging or any investigation. Any RH negative mother should be avoided any cross immunization, and O negative blood should be given to the patient, and anti-D immunoglobulin should be given to all the negative blood groups, and there is a Kluhar-Betke test which should be done in all the pregnant women where the uterine trauma is suspected. So whether should we go for investigations and radiographic investigations in pregnant women, or should we withhold them? So there is a level 3 statement that radiographic studies indicated in maternal evaluation, including abdominal CT scan, should not be delayed for fetal radiation. So it is like now a well-known fact that a fetus or a child up to the age of 3 can take 5 rats of radiation without having any complication. So without having any development complication. So any female with a fetus, the CT scan, if necessary, should not be deferred or delayed. Whenever possible, procedures not associated with ionizing radiation should be used. Yes, if like the patient is very stable and can ultrasound can detect all the things, then we should go for ultrasound. But if very necessary, when you are going for a renal injury or a bladder injury or such type of things, then a CT scan, if warranted, should be done. All females patients, if you are going for a chest X-ray or for a shoulder X-ray or for a knee X-ray, the abdomen should be guarded and shielded so that the fetal exposure is not there. So for blunt liver and splenic injuries and associated traumatic brain injuries, non-operative management is recommended for pregnant patients with these type of injuries, and the same things. If the patient is hemodynamically unstable, then we have to go for operative management. The same principles as for the general population. What happens if the patient is having a coagulation disorder along with the pregnancy? So, associated coagulation disorders in it is a contraindication for non-operative management because the patient may dip anytime and she may require or he may require, if a coagulation disorder is there, he may require operative management. So the patient should undergo operative management for all the things. Non-operative management is recommended in patients with pre-existing coagulation only if the facilities with adequate resources are there. If you have a blood bank with 24 hours and supply of blood products with cryo and FFP and everything, then you can go for NOM. If they are not present, then you have to go for operative management, like a splenic injury. If the blood bank and all the products are not possible to be obtained within like 10 minutes, then you should go for operative management. Hemodynamically unstable patients should immediately undergo damage control resuscitation and simultaneous correction of coagulation disorder. So whenever detected, basically the injuries which present, the coagulation disorders are always detected an hour or 2 hours later than the injuries. So till then, the decision has been made कि either the patient will go to NOM or operative management. But whenever the decision is made and the blood products, the blood investigations, you see that the patient is in coagulopathy, then you have to change your decision and reconsider your decision whether to proceed with NOM or just go for correction and operative management. So basically, there is a level 2A evidence that blunt liver injuries have higher complication rates with operative management. We all have seen that liver injuries are more often complicated with biliary fistulas and infections and hepatic necrosis and more prone to die after the operation rather than splenectomies. Complication rates increases with higher grades of injury. The grade 5 liver injuries are having more complication rates relative to grade 3 liver injuries. The most common cause of failure of non-operative management is hemorrhage. The patient may go into hemorrhage anytime and may need an operative management. And the management in failed NOM depends on the hemodynamic status. If the hemodynamic status is okay, then you can go for a interventional radiology, or you can just monitor the patient and wait for the hemostasis to occur. Operative management is recommended for hemodynamically unstable patients, that we all know. Operative management is recommended for hemodynamically stable patients with signs of ongoing bleed when IR facility is not available. That has been explained by Soumya, I think. And angiomyelization is recommended in hemodynamically stable patients with signs of ongoing bleeds. The same has been explained that any ongoing bleeds needs angiomyelization, and if angiomyelization is not there, you have to go for operative management. So, what should be the appropriate management strategy following biliary complications? So, incidence of biliary complications ranges from 4 to 7%, and it median time to develop is like 7 to 18 days, and the median time is 12 days. Most of the patients are managed non-operatively, and the initial management is ERCP and internal stenting, and non-operative management of the biliary fistula. Incidence of hepatic and perihepatic abscess ranges from 7.5 to 27%. They are treated symptomatically and ultrasound guided pigtail insertion, or operatively if it is very large or symptomatic or it has bursted. Hepatic and perihepatic abscess has a similar incidence rate among the operative group and the non-operative group. It is a level 4 case scenario basis statement. So image-guided percutaneous drainage with antibiotics is recommended as the first line of treatment. Surgical intervention is recommended when the percutaneous treatment has failed and is not feasible. That I have said already. So what is the appropriate management of hemophilia? Hemophilia is a very disastrous complication of hepatic injuries. So incidence of hemophilia varies from 0.3 to 1.5%. Selective angioembolization is recommended as the first line of.
Dr. Vivek, we are running out of time.
Yes, sir. Just 2 minutes.
Yeah.
I will just not go to the complications. We will go to directly the more relevant things. Discharge and follow-up protocols, which we should all know that when to discharge a patient with a non-operative management. So we recommend that a patient with blunt liver injury managed non-operatively should be followed at least 7 days after discharge. Ultrasound or contrast enhanced ultrasound may be done in place of CT scan at 7 days. Routine imaging at follow-up is not recommended in asymptomatic patients, and ultrasound is recommended in all the high-grade blunt liver or splenic injuries managed non-operatively. So usual follow-up is after 2 weeks and after 6 weeks. And by our best practice methods, the patient should be restrained from any heavy work like kicking, running up the stairs, lifting heavy weight, anything which raises the abdominal this pressure for at least 6 months, and strict bed rest for 6 months. That is recommended by the STAC. That is a grade C recommendation based on the papers and the literature research. So moderate activity may be allowed after 2 months, but till 6 months, no heavy work should be allowed. Thank you.
Thank you, sir, for providing us a complete overview on the management of liver trauma, along with managing other special situations. I would like to invite our third speaker for the day, Dr. Dinesh Bagaria, sir. He will be talking about pelvic trauma. Dr. Dinesh Bagaria is an associate professor in the Department of Surgery, Division of Trauma Surgery and Critical Care at AIMS, New Delhi. Over to you, sir.
Thank you very much, Parth. I hope my screen is visible and I'm clearly audible to you.
Yes, sir. Please go ahead.
Okay, thank you. So, namaskar. And till the time we have learned about the usual management of the trauma, which as a surgeon we do. But now I would like to take you in some unconventional unconventional imaging, unconventional injuries, which is the pelvic trauma. So by word pelvic trauma, the thing which come in our mind is that it is all about the bones, and why a surgeon or a trauma surgeon specifically should be ventured into this territory. But the one of the most critical part for management of these injuries, which I must say must be done by a surgeon or a trauma surgeon who is dealing with the trauma patients, and that is the hemorrhage control. So that is one important part which we should not expect from our orthopedic colleague to take care of, rather than we should do. And I am going to speak about this part in next few couple of minutes. So as Dr. Girish has already given a very comprehensive overview about the damage control resuscitation, and we do that for hemorrhage, and obviously control of the entry contamination. But hemorrhage after head injury is the second most common killer, as well as one of the most important etiology for a preventable death in blunt trauma patients. And one of the significant contributor definitely is the pelvic hemorrhage. Most of these patients where the pelvic trauma is significant, they coming into the shock or in extremities. If they are coming into the shock, I would say the mortality will be in range of 50%. And if they are in extremities, despite our best effort, most of the patient we are going to lose. Like I said, that when we see this X-ray, all we think is all about the bone, and we always will be concerned that why we should, as a general surgeon, as a trauma surgeon, should take care of these patients. But let me show you what is behind the bones, and that is all the vessels, medium vessels, large vessels, medium-sized vessels. And when the injury transferred is significant enough to break these bones, you can very well imagine what is going to happen to these vessels. And that's why the important part of initial management of pelvic trauma is the hemorrhage control, which need to be done by a surgeon. Most of these patients, the mechanism of injuries are either RTI or fall from height, ultimately leading to the pelvic fracture. And as I said, the transfer of energy, pelvic bones, they are considered one of the most solid bone, most strongest bone in the body. And if the transfer of energy is so significant that they are able to break the pelvic bone, you can very well imagine what is going to happen. The soft tissue, soft organs in the form of bladder or bowel inside the abdomen, which is lying into the pelvic cavity. And that's why most of the time these patients are polytrauma patients rather than in isolation. And as I said, the most important concern which we are considering is about the hemorrhage control. And in 85% of these patients, the origin of hemorrhage is from the venous origin, and in 15% it will be the arterial hemorrhage. And this kind of statistics will determine how we are going to deal with this hemorrhage part. So ED management, the initial management, I think Dr. Girish has taken care of this part in very comprehensive manner. But just to recall that we start with the primary survey, we do the resuscitation, and at the same time, because it is a dynamic situation, we keep on reevaluating till the patient is stabilized. And after that, we do the detailed secondary survey to find out the other injuries which probably are not going to kill the patient in the first hour, but maybe later on. We reevaluate, and depending upon the need of the patient, we do the defined care. There are certain adjunct for the primary care as well as the secondary care. So in the primary survey, our concern is to diagnose and manage the immediate life-threatening injuries, while the other injuries which may turn out the potential life-threatening injuries, we will deal after doing the secondary survey. So when we should suspect the pelvic injury? In a patient who are hemodynamically unstable, and most of the time they may be without intraperitoneal fluid on fast examination. If we are doing some clinical test, one of the is pelvic compression test. Maybe it may some sort of controversial, because people will even say that if there is suspected fracture in the pelvis, you should not touch it even. But it is not like that. A good experienced clinical examination is very important in the pelvic fracture patients also. If there is suspected limb length discrepancy or the rotational deformity. Besides that, the other clinical finding in the form of hematoma in the perineal region and suspected urethral injury will also give you clue about that this patient might be having pelvic injuries. And as I said, the pelvic compression test is a very important test in initial examination during the primary survey. And in any patient, when the pelvic compression test is positive, we suspect that pelvis is fractured. And in a hemodynamically unstable patient, we will not rule out these pelvic injuries as a cause of hemorrhage until proven otherwise. So how to do the pelvic test, pelvic compression test? It is just a clinical examination of manipulation of pelvic bone by putting your both hand in the anterior superior iliac spine and trying to rotate them medially as well as pushing them backwardly. And if you are able to find any movement or any crepitation, you consider that there is some sort of fracture and you consider the pelvic test positive. So if the patient is hemodynamically unstable, the management is as described by the previous speaker, following the ATLS guideline, starting the massive transfusion protocol, tranexamic acid, and the pelvic binder. So when to apply pelvic binder? So pelvic binder is kind of a, you can say a brand name, but the actual name of this device is PCCD, that is pelvic circumferential compression device. And the name itself suggests that it will compress the pelvis circumferentially to reduce the volume. So if there is any mechanism of injury, we suspect that there is made with pelvic fracture, or the patient is hemodynamically unstable, GCS is low, he is not able to comprehend our commands, and the distracting injuries or any abnormal clinical assessment of pelvis, there is no harm in applying the pelvic binder. And if none of them is there, then probably binder is not required. As I said, it will reduce the volume. So the fractured bony part will be stabilized. There will be decreased hemorrhage. It will create a tamponade effect, reducing the venous disruption and bleeding, and will help us to maintain the integrity of the pelvis if we need to do the pelvic packing, as well as the time for definitive stabilization will be reduced. So is this the right way? I won't say it is the right way, but it is not a preferred way. Sometimes in pre-hospital setting, the pelvic binder is being applied like this only, but the right way is like this, where we roll the patient, log roll the patient, we push a folded sheet of the bed sheet or any other sheet below the patient, and then we circumferentially rotate it one flap over the other, and we pull and bilaterally to reduce the volume and applying the pelvic sheet as pelvic binder. There are commercially pelvic binder are also available, which can be used, but in most of our setting, be in the pre-hospital setting or in the hospital setting, we using these bed sheets or some specific cloths as a pelvic binder. And once we have stretched the sheets, we fix it by towel clip or any other mean. So this is how a pelvic binder should be applied. But the problem is where to apply. So it should be applied at the level of greater trochanter. And one study showed that in most of the applied outside applied pelvic binders, it is only around the 50 to 60% where the application is done at right position. Otherwise, most of the time, either it will be upside or it will be the lower side. We can try, we will try to take it out as early as possible, but at least not more than 24-hour a pelvic binder should be keep on. So once we have done the clinical assessment, initial clinical assessment, the second part which we can use for our to gain more information is the radiological adjunct. And one radiological adjunct which we use in suspected pelvic fracture patient is pelvic X-ray. Just a few words about how to read the pelvic X-ray for the benefit of the residents. So we are concerned about the 3 circle, 1 big circle, 2 small circle, 3 line, 1 is the Shenton line, iliopectineal line, and ilioischial line, and 3 joints besides other bones in the form of pubis, acetabulum, acetabular floor, crest, vertebra, and then 3 joints which are 2 sacro iliac joint and pubic symphysis joint. So if there is any deviation, any disruption of these lines, these joints, these bones, that will be considered as a pelvic fracture. There are certain classification. One is the tile classification, and other more commonly used is the Young and Burgess classification. But these classification will give us a only clue about high association of the vascular injury or any other injuries, rather than giving any actual clinical status. And fracture classification, it will not predict the outcome as well as the hemodynamic status of the patient. So let's come to the management part. And the 3 important pillars of management of pelvic fracture are mechanical stabilization and venous bleeding control and arterial bleeding control. The mechanical stabilization can be done by using pelvic binder or PCCD, as I said, or it can be done by using some rings or external fixator. But external fixator and these mechanical stabilization will take time, and you may not have good resources to use them in your ED. This is the one study which was done on cadaveric after applying PCCD versus certain external device in the form of T-pod, and they showed that there is no difference in the stability which is being done by the external fixator or a T-pod or pelvic binder, and that's why using pelvic binder or pelvic compression device is very well recommended. The second and most important line of defense for pelvic hemorrhage management is pelvic packing. Why? Because as I said, in 85% of patients, it is the venous origin of the bleeding which is happening. And that's why pelvic compression is going to be achieved by pelvic packing. So there are two approaches. One is total extraperitoneal approach, and second is the intraperitoneal approach. First, let's see how this is being done. So this is video about total extraperitoneal approach, where we give a infra-umbilical incision. Either it can be given in the midline, or it can be given as a incision, phalansteal incision. And once we are in the extraperitoneal space of radius around the bladder, we will push 2 or 3 pads on either side of the bladder posteriorly, so that final lie of the pad will be just anterior to the sacrum promontory, where the venous plexus is there. So it will be putting the pressure on the venous promontory, on the venous plexus around the sacrum. So this is how a total extraperitoneal approach of the pelvic packing is done. Second approach is the intraperitoneal approach. In this approach, once we have done the laparotomy and ruled out any other intraperitoneal source, now we will kind of shear off this bladder as well as the peritoneal fold from the inner surface of the pelvic ring. And then when the dead space has been created by the hematoma or by our separation, we will push again 2 or 3 pads on either side of the bladder into the space of radius posteriorly. So this is the final lie, as I said, where the packs will lie, final lie will be along the bony surface of the pelvic rings. Which approach is preferred? So in our scenario, where the blunt injuries are more, and most of the time these patients will be polytrauma patients. In our practice, in our experience, these 35% of patients will be fast positive. And in these patients, you won't be able to rule out the intraperitoneal source also. That's why our usual approach is intraperitoneal approach. And the third important line of defense is to control arterial bleeding in 15 to 20% of patients, and in some 5 to 10% of patients where we won't be able to control the bleeding after venous packing, or the primary source is the arterial only. They require some sort of hemorrhage control maneuver to control the arterial bleeding. And as of now, the 3 options, one is the REBOA. REBOA is the acronym. The full definition is the resuscitative endovascular balloon occlusion of aorta. So it is a temporary measure, I would say, where we deploy a balloon catheter through the femoral root into the aorta and occlude the aorta, so that the blood flow into the pelvic bone is in the pelvic area is reduced or completely cut off, so that it will give us a time till the time we can arrange the surgery part or the interventional radiology part. So it is a bridging procedure to give us more time. Most of the guideline, most of the literature, most of the seminars or lecture from the people around the world, if we listen, all will concentrate only on the interventional radiology, and they will say that the treatment of choice is the interventional radiology. But in a resource constrained setting like ours, where few centers may not be having even interventional radiology, and in the centers where the interventional radiology is there but may not be available in the off hours, interventional radiology is and cannot be a treatment of choice for such patients in these settings. And that's why we need to find out something which can be done surgically, and that is nothing other than bilateral ligation of internal iliac arteries. Again, the approach are two: transperitoneal approach or extraperitoneal approach. In transperitoneal approach, we will find the common iliac artery by tracing the aorta downward, and once we have traced the common iliac artery, we will trace it down for internal iliac artery and external iliac artery, and at the same time we will try to avoid injury to the ureter. And once we have identified the internal iliac artery, we will separate it from other vessels and underlying vessels, and we will either ligate or we will apply the clip. And this will be done bilaterally. So this is still photograph. You can say this is in the right side. So this is the common iliac. This is the internal iliac with clip applied over it, and this is the ureter. And this is in the left side. This is the external iliac. This is the internal iliac with a clip over it, and this is the ureter. So this is approach in the when we are doing laparotomy. So transperitoneal approach in few patients. Again, in this patient, it is shown the transperitoneally only. But if we are doing extraperitoneal approach for the pelvic packing, at the same time, if we shear off the peritoneum more medially, then we will be able to see the common iliac and its bifurcation. And like we do in the intraperitoneal approach, same maneuver can be done in the extraperitoneal approach, and you can separate the internal iliac and ligate. So recently we published our experience by this procedure, around 6-year experience by bilateral internal iliac ligation along with the preperitoneal approach at our center, and we could able to show the results which are as per the world literature. A few words about the angioembolization, though most of the time it won't be available, but if it is available, definitely it is a good treatment choice, and you do the DSA, and if there is any bleeding vessel, selective or non-selective angioembolization can be done. The definitive fixation here is the part which need to be taken care by our orthopedic colleague as early as possible once we have stabilized the patient, so that patient can return back to the pre-morbid state and his routine life. So as a protocol, we do the primary survey, ABCDE. If patient is stable or unstable, if unstable, start with the fluid resuscitation. Either he will be responding or he will not be a non-responder. If it is non-responder, nothing sort of OR, if possible, can do the pelvic X-ray just to kind of reinstate or support your decision. If patient is responder, do the detailed secondary examination and to rule out any other injuries associated. At the same time, if you are suspecting pelvic fracture, the one important consideration should be suspecting the urethral injuries. And other imaging in the form of CT abdomen, CT torso should be done to rule out other injuries. And as per the injury find, further management can be done. By this time, if any during this management protocol, if any time, if there is clinical deterioration, again, patient should undergo either intervention or operative treatment, depend upon the condition of the patients. Most of the centers where the experience and the resources may not be good enough to deal with the such patients, so early decision to transfer to higher center should be considered, and certain things which we can take care of before transferring is that we should continue with the optimum resuscitation, blood product transfusion with a pelvic compression device applied, as well as proper communication with the receiving facility, and a protocolized approach of transfer is SBAR as per the ATLS guidelines, which should be used by any center if they are transferring the trauma patients to higher center. Though it is a kind of show run by surgeon or trauma surgeon, but overall holistic management is a multidisciplinary approach, because you cannot alone do everything. The initial assessment and initial management may be done by the emergency medicine team, followed by intervention radiology or anesthetic colleague in the critical care part, and then come the management, final management by the orthopedics. So my take-home message that pelvic fracture hemorrhage is a responsibility of a surgeon, trauma surgeon, whatever we call the person who is taking care of trauma patients. And pelvic compression device is a simple measure which can save lives if promoted very judiciously, very rigorously while transferring the patient either in the pre-hospital setting or during the inter-hospital transfer. And whatever measures, whatever techniques, whatever resources we have, they all are complementary, and we should use them as a protocolized approach one after another rather than in a competitive manner. Thank you very much for the opportunity. Thank you to all the TUGSS office bearer for this exciting opportunity. Thank you.
Thank you, sir, for the excellent talk on pelvic trauma. I never knew there was so much to learn about the pelvic trauma as well. Now we will move on to questions. We don't have much time, so we'll quickly start with the questions. Uh, the first question, Dr. Girish Bakshi sir had to attend to a patient, so he had to leave. Uh, so the first question is, which energy source should be used for controlling liver injuries, and what is the current level of evidence for the same? Dr. Subodh Kumar sir, would you like to enlighten us on this?
A very good evening to all. Thank you very much. It's a very, very pertinent question, but I would like to say that in emergency setting, if patient is a non-responder and you are doing a damage control laparoscopy for liver injury, no need to use any energy sources. You have to just do the perihepatic packing. And the word perihepatic is the most important thing. Do a perihepatic packing and come out as quickly as possible, right? So use of energy sources is that you have opened the abdomen for something else and you find a liver laceration which is oozing, mild bleeding, then you can use all these things, the energy sources and suturing of the laceration. But in case of damage control laparotomy, nothing short of perihepatic packing.
Okay, sir. Thank you. Moving on to the next question. What is the best method to evaluate fluid response in trauma patients? I think we can direct this to Dr. Mabel Vasnayak. What is the role of CVP measurements, and what is the best method and a faster method to measure fluid resuscitation? Or any of the other panelists and speakers can take the question.
The best way to measure the adequate resuscitation is very simple, and it's a urine output. So because 2-3 reasons. Number one, the CVP is not reliable. Number two, we don't put central lines in ED, right? It requires a lot of training and positioning of the patient, which is not recommended. There is a cervical collar in place, right?
Yes,
so, and sometimes you don't get the even the venous access, so you have to resort to the intraosseous fluid management. So there is no role of CVP measurement or something else. The best guide for resuscitation is urine output.
Okay. Moving on to the third question. What is your opinion
Dr.
about
Mabel,
mental?
Dr. Mabel, Dr.
Yeah.
Mabel want to speak something because she
Okay.
was muted.
I was muted and so I couldn't speak. I do agree that there is no role for
Yes.
CVP at all to measure fluid output. I would go by again urine as well as urine. So you need to have at least 0.5 ml per kg per hour as an you know, a parameter of adequate resuscitation. Also, using the fast would be good because you can see the IVC. So the IVC would tell you whether your fluid resuscitation is adequate, and then hemodynamic improvement of the patient is what I would go by. Yeah.
Okay.
So you mean to say the ultrasound, not fast?
Yes,
fast has a
ultrasound.
different, yeah,
Not fast, sorry. The ultrasound to see the IVC.
Because fast gives a different message.
Yes. Yes. Yeah.
Thank you, ma'am. Next question is, what is the role of mental auto-transplantation of spleen in high-grade splenic trauma in children? Any one of the panelists and speakers can take this question.
I think Krishna can answer this.
So I think so. Maybe we have never done a mental auto transplantation in.
Not yes, absolutely right, and it's not recommended at all. See, all
It's
these
not recommended,
procedures are
obviously.
historical, and
And they're
people have
time-consuming.
described, time consuming and historical, and people have described that this can be done, this can be done. The idea is that in adults, the spleen can be very well sacrificed, right? So in case of damage control laparotomy, if spleen is bleeding, you have to just remove. And if you have done the laparotomy for some other reason and you find there is a splenic injury which is not bleeding, you can leave. No need to mental wrapping or any suture. But sacrificing, the only precaution you must take while doing the splenectomy, that you should not injure the pancreatic tail. So you should, that's a very technical part, that you should remain close to the spleen, not towards the pancreas. But splenectomy is a very safe procedure. Every surgeon managing trauma should know how to do it. And I must congratulate Soumya for beautifully describing the guidelines. And in our country, which is a developing country, still there is a role of splenectomy in these patients.
So can I speak something about this auto transplantation?
Yes, sir.
Yes, why not?
We actually also we tried to answer this question in our guideline also. The studies, the reports showed no actual benefit in terms of immune protection after auto transplantation, and it is also time consuming. And there are lots of reports of OPSI, post-penectomy infection, even after transplantation. So there is actually benefit is not definite. So we do not recommend auto transplantation where the patient is hemodynamically unstable and we have a very limited time to save the patient.
Okay.
Dr. Subodh and Dr. Bagadia, it's Dr. Vikas here. I just want to ask a practical question that if the patient, some patient has an isolated uterine injury, does the gynecologist is required in those cases mandatory?
Uterine injury?
Yes, sir. Isolated uterine injury.
Following what? Because
it's difficult to say because sometimes patient doesn't give history of any sexual assault.
So if you are doing damage control, just tie the artery and come out.
No, sir. If it is not a road traffic accident.
So if it is what? So patient is stable or not?
It can be a sexual assault.
No. The point is the bottom line of any management is determined by the hemodynamic stability of the patient. If patient is hemodynamically stable, you have time at your hand and you can call anyone, you can do repair, whatever you want to do, right? But if patient is hemodynamically unstable, nothing short of ligation of the vessel and come out. So first you need to see, you cannot pose a hypothetical question. You have to give what is the hemodynamic status of the patient. If the uterine artery is injured during elective surgery, you are doing something else, then of course you will try to repair or you call a vascular surgeon or whatever. But in trauma setting, we are discussing about the trauma setting. We need to decide whether patient is stable or not. I think Dr. Girish wants to add something.
No, absolutely. I go with what you are telling, sir. Absolutely correct that obviously the criteria is hemodynamic instability. If he's talking about if the patient, we see a lot of patient following DNC and done and private or rural setup, and then there is a uterine perforation. That is altogether a different game, which is primarily managed by gynecologists rather than coming to trauma surgeons.
Absolutely.
So that is a total different ball game actually.
Just to substantiate the discussion just happened that recently we came across a patient who was 34-35 week pregnant, and following RTI, when we evaluated, there was a big hematoma around the uterus. So actually we were not knowing what it can be, and the patient was having abdominal sign symptoms. So just to rule out the bowel source, we did the laparoscopy first, diagnostic laparoscopy, and during the time when we manipulated the hematoma, it started bleeding. There was a kind of uterine perforation, you can say, or tear. We need to open the patient and we control the bleeding. Now, because the fetus was live and it was a precious fetus, precious child in terms of gynae terminologies, and once the patient was stabilized, at the same time we called our gynae colleague that, okay, we have taken care of damage control. Now you can think and you can discuss what is to be done next as far as the continuation of the pregnancy is concerned. So the management of hemodynamics rather than the management of organ injury, that is to be done by a general surgeon or trauma surgeon, whosoever is taking care of the trauma patient, irrespective of injury organ. In fact,
absolutely.
If our center, if there is even cardiac injury, chest injury, vascular injury, whatever kind of injury it is there, it is primarily will be done by us only rather than in a specific organ patient,
Yes,
surgeon.
So there's a clarification from the in the chat box, Dr. Dinesh sir. Can you please clarify on the indication for CT in a pregnant woman? Whether we should go for
Can I take the
CT?
question?
Yes, ma'am.
Yeah. So the mother comes first. So if a CT is needed for a pregnant lady, then we should go ahead. You can, put a field or whatever and go ahead and do it.
Absolutely,
Because if
Dr.
you're doing
Mehta.
a CT for a pregnant lady, it's because you need to see what exactly is the problem with her. So mother first and then the baby. So you
So
need
if
to
you
save
say
the mother, you need to stabilize the mother first. Yeah.
the keyword here is, Dr. Mabel rightly hit the nail. Keyword is if it is indicated.
Yes.
Right? If it is indicated, it should be done. You save the mother, then you will save the child.
Yeah.
Can I make a quick comments about
Yes, sir.
the talks? So Dr.
Why not?
Girish beautifully described the damage control registration. I just want to add 1 or 2 points that damage control resuscitation. The two things, the timeline about the damage control surgery 3 after the resuscitation in ICU is generally 48 to 72 hours, but you have to see the parameters which you use to decide the need for damage control laparotomy. They should be returned to the normal or near normal, number one. Number two, it is not that you have to take the patient to the OR for a definitive surgery after 48 hours. You need to do another round of damage control surgery and come back. So patient may require multiple visits to the OR, and it happens, right? So it could be a damage control surgery 3A, 3B, 3C, 3D, 3F, and so on and so forth, right? This is the message I want to give. And you beautifully described the lecture, the damage control registration. Soumya did a wonderful job. Both Soumya and Vivek, they were involved deeply in the management of these guidelines, and that is why they could present so beautifully these guidelines. And Dinesh beautifully described the management of pelvic trauma. I just want to reiterate here, and we publish this also, because in the developed countries and Western world, they do angioembolization, and this paper was rejected by the Western world that we will not publish because you are saying the very old method of ligation of bilateral internal iliac arteries. So we publish in Indian Journal of Surgery, and they graciously accepted and published our paper. And soon after, the same article was published in Injury. And actually, Dinesh showed also, he wrote a letter to the editor. The same article that there is a role of pelvic packing and bilateral internal iliac artery in a resource constrained setting. And India is a resource constrained setting. So that is why he wrote to the editor of the Injury. And I want to put it on record that there is a bias, some bias against us in the developed countries. So I am very happy that you organized this webinar on trauma. I congratulate Dr. Vikas Jain, the TUGSS India, Dr. Partha Gada, and your whole team. Thank you. Thank you very much.
Thank you, sir, for your closing remarks.
Can I just say
Yes,
a word? Yeah.
Yes, ma'am.
Also, like to say that all the speakers have talked about it, but I'd also like to emphasize that initial management primary survey is very, very important in the management of a trauma patient, and it involves teamwork. So it's important to have a trauma team. So you have a sick trauma patient, you have a trauma team, but all the stakeholders come, and one can never overemphasize proper initial management. So primary survey adjuncts to primary survey goes a long way in really stabilizing a patient and decreasing the morbidity of the patient.
thank you, ma'am. Closing remarks from Dr. Krishna Asuri, sir.
Thank you very much. Thank you very much, Dr. Vikas, for inviting me to this talk. And I'd like to congratulate all the speakers. It was very well presented, and Dr. Dinesh, it was a very well presented. I used to love pelvic trauma when I used to be a senior resident in trauma center, and extraperitoneal blocking was something which I used to really love, and it was beautifully demonstrated in your videos, and I think so it was very informational, and Dr. Subodh has given apt comments on all the talks, and I congratulate the entire team for the excellent presentations. Thank you.
Thank you, sir. If anyone wants to say anything, or I would like to uh, introduce you to the topics of the next meeting. The date for the 19th TUGSS India Academics is 9th of June, which is at the same day. And the theme for the next meeting will be on robotic surgery. The topics you can see on the screen. I've also shared the link to join the WhatsApp group where you can find more updates regarding the same. Um, Dr. Vikas Jain, is there anything? Can we conclude the session today?
Yeah, definitely we can.
Okay. I thank
We
you
can.
all for joining. It has been a wonderful session talking about trauma, and I hope all the participants can take all these learnings into their clinical practice. And thank you all for joining.
Thank you.
Thank you
Thank you
very
very
much.
much. Thank you very much.
Thank you.
Thank you.
Thank you, sir. Thank you, everyone.